Welcome to End of Life University on YouTube. Today, I'm sharing with you a conversation I had with Dr. Libby Sallnow from the UK. She is one of the co-authors of the Lancet Commission report on the value of death. And we have just a phenomenal conversation. I know you're going to enjoy this, so stay tuned for that. If you haven't already, be sure and subscribe to this channel. Also, subscribe and leave a rating and review wherever you listen to the podcast. And if you're so inclined, you can really help keep this show on the air by making a small financial contribution. And you can go to eoluniversity.com/support. You'll find 3 different ways you can make a donation. And I thanks in advance. That will help so much. So we'll move on with my conversation with Dr. Libby Sallnow. Today, I'm so happy to welcome my guest, Dr. Libby Sallnow, coming from London. And I'm so grateful for her presence here. And I'll read her bio, very impressive bio for everyone, just so you can get to know Libby. Dr. Libby Sallnow is a palliative medicine consultant and an honorary senior lecturer at St. Christopher's Hospice and the UCL Marie Curie Palliative Care Research Department in the UK. She has helped lead and develop the fields of new public health approaches to end-of-life care, compassionate communities, and social approaches to death, dying, and loss over the past 2 decades in the UK and internationally. Her PhD explored the translation of a model of compassionate communities from Kerala, India to London, UK. She has published over 25 articles and book chapters in these fields and co-edited the book International Perspectives on Public Health and Palliative Care in 2011. She is an honorary consultant at the World Health Organization Collaborating Center for Palliative Care in Kerala, India, Vice President of Public Health Palliative Care International, the President of the Palliative Care Section of the Royal Society of Medicine in the UK, and the first author of the new Lancet Commission on the Value of Death, Bringing Death Back into Life. And we'll be talking about that report a great deal today. So, Libby, thank you so very much for joining me. And I've been looking forward to this conversation for weeks now.
It's so kind of you to invite me. I'm really looking forward to unpicking some of the different issues that we can discuss today. Thank you.
Yes, and there's so much. So, I mean, I know we could go many different directions, but maybe you could just start with your own story and what inspired you to do so much work in this arena of end-of-life care.
Yeah, so for me, death and dying and loss have always seemed as really key integral parts of all our lives. And I experienced, as many people have, various family bereavements when I was younger, as a child and as a teenager. And I really came to see how people responded to these events. And I often wanted to talk about them and saw them as part of my life, whereas a lot of often adults kind of shrunk away and actually didn't feel that these were key things that we needed to talk about, and actually seemed almost embarrassed to try and talk about these things. So I had a really key sense from really quite young that actually these events are ones that people don't want to talk about, but actually that we should. So as I went into medicine and training, I found the specialty of palliative care, and it just seemed to really resonate with a lot of the ideas that I had around the kind of social nature of many of the challenges that we face, and the importance of responding to these universal issues with a kind of holistic social model, as well as good healthcare and good medicine. So palliative care really resonated. A lot of senior consultants were saying, "Oh, don't do that, you'll never cure anyone, do oncology." And it just really compounded my idea that actually, no, this is a really key field. It's a really key part of society and a key part of medicine. And so I was focused on that really throughout my medical training. And when I went as part of my training to Kerala back in 2003, I think that's where I really began to understand the power of a much bigger response than just a medical or just a clinical or just a professional response to end-of-life care. And in Kerala, we can talk more about it, but they've really transformed a real paradigm shift in what death, dying and grieving means, and whose responsibility it is to care at those times and how you can really shift experiences. And I saw such an amazing model in action there, that really at that quite an early start of my career allowed me to think or imagine what could be possible if we really shifted the way we care and understand death, dying, and loss.
And I can see the title of the Lancet Commission report is on the value of death, bringing death back into life. And I can see that that has been your perspective all along, even from the time you were very young, that death has value and we should not be relegating it, off in the corners, even in the corners of our minds. We should keep it top of mind and be aware of it at all times.
Yeah, absolutely. And we wanted to say, it's not to say that death is not hugely sad and distressing, and we kind of acknowledge that, but it is an integral part of our lives. And actually one of the core contentions of the Lancet Commission is that by ignoring it and kind of relegating it to the sidelines or hiding it, it actually makes it, and essentially devaluing it, it makes it so much harder to then manage. It kind of magnifies the challenges that come with it. So it needs to have its place. It bookends our lives. It's part of our lives, whether we would like it to be or not. And so by ignoring it, actually, it just compounds the challenges.
And we often talk here in the US about how it's been over the last a little more than a century that death came from taking place in people's homes, but was brought into hospitals. And that's where this idea that death is a physiological occurrence, a medical occurrence, really took hold. And once we removed it from people's awareness and sight, our only approach then became medical, and the medical profession, I would say here, didn't do the best job of helping people with death and dying. And so part of our conundrum is we just lost touch in our communities with how to manage death, dying, and grief as well.
And you're absolutely right. That was the real trigger, the impetus for the Lancet Commission into the value of death. And it was this idea, this kind of premise: has death become over medicalized? Because it's shifted so much really over just a couple of generations, to say, where it used to be an event that was taking place at home and was overseen by family or religious or other people within a community who were aware, and now it's in hospital. And it's not to say that all is wrong, because we now have palliative care, or now we have pain relief, not for everyone, but increasing access to symptom control, etc. But there's been a shift, and actually the hospitals often don't want to be the kind of custodians of death and dying. They're not set up for that. So what we're seeing is this big shift has happened, and we trace many of the kind of reasons and triggers to why death now takes place in institutions and why it's taking place under the kind of care and gaze of the professionals. But actually what we're seeing is this system essentially that's shifted, and death now takes place in these institutions. They're not set up for managing it, and the outcomes are poor. So actually, and if we could begin looking at why those shifts happened and how we could maybe reimagine and realign some of that, then we could improve experiences that at the moment we can see dying is often prolonged. Experiences are worse when people are in places they don't wish to be in, and having care that isn't centered on them as people, it's them as patients.
Yes, that's so true. And I was curious, when I first was introduced to the Lancet Commission report on the value of death, I was just amazed. I was blown away because it just contained all the deeper things that I thought and felt about death and dying. And it was so inspiring to see it in a report that came from the Lancet Commission. And I'm really curious about how that all came about. And you became one of the co-authors of the report.
Well, interestingly, the actual reason for how the term, the value of death, came is there was a commission on the value of life, and that was hasn't been published yet, but that was looking at kind of the role of religion and the role of life and healthcare, and kind of trying to pull out the complexity around that. And that, as I said, still in process. And the flip side of that, then the team at the Lancet, in conversation with people, thought, well, actually, the value of death, we can't look at one without the other. And so that's how that kind of the idea came into being. And as I mentioned, the kind of central impetus or premise was death has become over medicalized. That's a problem. And how can we understand that? And there'd been a palliative care commission published in 2017, which is looking at access to pain relief and to palliative care. through a global lens and really picked up the inequities globally around access to opioids and the palliative care approach, and looked at ideas of serious health-related suffering, etc. And so that was a discrete piece of work that the Lancet were really keen that we didn't kind of replicate that. And so they wanted us to have a really broad understanding. And that's where I think the value of this report is, that actually we went out really wide to philosophers, economists, social scientists, obviously doctors and nurses, but beyond palliative care, and philosophers and people looking at different religious commentators and perspectives. So it was really broad, and we specifically didn't want it to come from a healthcare lens. And so that was part of the unpacking at the beginning of how are we going to do justice to such a big issue. But we were really clear that you could not find the solution to the fact that death has become over medicalized from within a healthcare setting. So we necessarily needed to look outside that, which led to the tremendous the diversity and the different kind of contributions of all the commissioners, which was, I'd say, quite hard to pull into a coherent document. But that was the kind of the benefit and the interest and the joy, really, of having so many different perspectives. And I hope that comes across, because there was such a richness in contribution to it.
Well, absolutely, it does absolutely come across, and it impressed me so much because I've realized for a while now we're not going to fix death and dying from within the medical system alone, because that's where the problem has been created, and we have to have bigger, broader thinking, and that in terms of we have to collaborate with every other perspective, every other stakeholder in death and dying, which is really everything in every arena. And so I appreciate so much the broad approach that you have taken in the report. And you mentioned the need to rebalance death and dying, and that comes through as one of, I guess one of the core features of the report. So would you talk a little bit about that, about the need for balance once again?
But as we began to explore this question, this idea, is death over medicalized, we began to realize that actually it isn't, as with none of these things, it's not a simple answer to say yes or no, because in many places death is over medicalized, where dying is prolonged with treatments that people don't wish to have. And that's what the advanced care planning movement has come to protect us and move against, to say treatments that people would not wish to have, because the healthcare it's almost become a kind of juggernaut. You can't stop it. Whereas in many other settings globally, from low, high and middle income countries, there are people who can't access basic healthcare, basic preventative care, basic disease management, and certainly not palliative care and care at the end of life. So it wasn't as easy to say as we need to pull back all of medicine and all of healthcare from death and dying. In some places, people will need more. And the Palliative Care Commission from the Lancet really articulated this stark inequity. That's one of the most shocking inequities that they highlighted. So we kind of have this idea that actually it's a paradox. We're trying to ask for different things for different people. But what we understand is that the entire system is unbalanced. And we began using this term very clearly, the idea that actually this isn't just healthcare that's managing death and dying. It isn't just communities that's managing this. It's a whole system, and much like we interact with kind of financial systems, educational systems, there's this death, dying and care and grieving take place within these complex systems. And so one of the challenges really to begin balancing it, as we say that it's unbalanced at the moment, towards the kind of healthcare, the relentless treatments, the control, which then disempowers communities, families, and becomes really a vicious cycle. To begin rebalancing that, we need to first understand who else is in this system. And this is one of the key things that we were saying, at the moment, healthcare is the predominant person. And movements like compassionate communities that we can come on to, a new public health approaches, are trying to bring in the role of the community to say, why is this voice silent? Communities have a huge fundamental role in care at these times and have a responsibility and a right to be involved. So how can we begin shifting that? And then beyond that, we need to look at some of the economics. What things are driving the biomedical research? What's this idea that we will cure every illness, and the funding that goes towards end of life care or any kind of death, dying and loss research, support, etc., is infinitesimally tiny. And there's other parts of the system that we need to start shifting to allow a really tangible change in how people experience these times. And two of the key players are really kind of community resource strength and capacity and the healthcare team. But there's so many other parts of this system. And one of the things is making them explicit, naming them, understanding who are the other people who and the other institutions and processes that influence how, where, and why we die and care.
Mm. Oh, that's such a good point. And it makes me recognize that here in the US, at least, we have a terrible problem with disparities and inequities in end of life care. And there are entire communities of people who are not really receiving good quality healthcare, even throughout their lives, but also at the end of life. And so this emphasis on a community focus means all communities, that we bring all of the communities in. And if we've already disenfranchised a community in the first place from healthcare, then of course there will be inequities in the care at the end of life.
Absolutely. And your point is really key, that the kind of determinants of why people have been able to or not been able to access healthcare services or make decisions about their lives that affect their health and their health outcomes, commonly known as the social and structural determinants of health. We're really used to using that term when we think about health and well-being. And we know that the kind of these social and structural determinants far exceed and outweigh the healthcare contribution. There's studies to show, healthcare, anywhere between kind of 10 to 25% of our health outcomes are determined by health care services, and the rest is determined by the relationships around us, the food we eat, the air we breathe, the ability we have to make a decision, how the amount of control we have over our lives. And so that's really common and accepted in the kind of health and well-being literature. But somehow when you get to end of life, when someone is diagnosed with a life-limiting condition, the focus absolutely goes on to the provision of services, and the carers, family, communities are just really pushed to the peripheries. And often the families and communities might step to the peripheries because they feel like this isn't my space, and so this isn't my role. And so what in the commission we were really trying to bring out is actually these social and structural determinants run right through our lives, and they are often even more magnified in where people die, the ability for people to die with the people around them in a manner in which they would choose, and the resources, the relationships, that kind of health literacy, which often now known as death literacy around that time, that continues. And so somehow we've kind of forgotten that. We're trying to fix these times with increased services, and we need good services, of course, and we need great access to high quality services, but they cannot be the entirety of our response when people are dying and when people are caring for loved ones. So that kind of comes back to that sense of rebalance. How can we bring that recognition into this space?
And you're so right, because improving services, it's like treating one of the symptoms of the problem, which we know in medicine is not the best approach if we're not really looking at what underlies that. If all we're doing is treating symptoms, we are not going to make the progress we'd like to make.
Absolutely.
And one of my favorite parts of this report is the fact that you were able to distill it down to what this the 5 principles of a realistic utopia, which I love it because it's a vast report full of information, but you've been able to just really summarize everything in these 5 principles, and they're so profound, but it's such a wonderful guideline for what needs to happen. And I'm hoping we can just kind of dive into each one of those 5 principles, because they're really brilliant.
And we really wanted, and we're challenged by the team at the Lancet to kind of move beyond just rehearsing the challenges. And that's, we go through in the beginning part of the report, really understanding what's it like, what is contemporary death, dying and loss like, what's wrong, what's working, what's changed. But then we wanted to then shift to think to the future and to acknowledge that all of us have got a role within these systems, and they're constantly changing, and how people die in 30 years will be different from today and how they will be in 60 years. And we wanted to highlight that we've got a role in that kind of intentional part. And if we don't do anything, they will continue to change. And so we then challenged the commissioners to say, okay, well, what would a future look like that involved dying, that people were able to die, care, grieve in the way that they would wish to? What would we need to be in place for that to happen? And so starting from that kind of positive perspective, we then worked back and said, what would be the principles? And because we were always holding a global frame for this report, we really wanted this to be relevant for global communities. Now, that's obviously really difficult. The context is so different in different places for different people within countries, yet alone between countries. So they're high level because we wanted them to resonate. And the idea is that people interpret them for their local context or for their country. But we worked hard to find something that absolutely distilled all of the report, and then hopefully would be inspiring and trigger people to think, okay, I'm going to take one of these and really work on them, or I'm going to try and bring a series of these into my action. And the really good thing is that these principles are already in action in multiple settings and contexts around the world. And one of the tables towards the end is where we went through and found examples of where this is already happening. So although we use the term a realistic utopia as something quite kind of radical but achievable, it's already happening. And the challenge is really how we just spread those principles and make them realized everywhere rather than just kind of discrete projects.
Which is wonderful, because there are models out there that we can use to help us once we identify in our own communities where we need to begin and what our most pressing problems are. And so the first principle deals with what we already discussed a bit, the social determinants of death, dying, and grieving. I'm really glad you included grieving, because I think sometimes grieving gets left out when we talk about death and dying, but it's an integral part of that entire process.
Yeah, and here we were trying to kind of talk about the kind of the inequities that people live with throughout their lives, and how they don't get forgotten, they actually get magnified when people are dying. And often they'll determine what cause of your death, what people are dying from, the conditions that you'll have, their ability to where you will die, in hospital or at home or in a care home, etc. And so we wanted to say we need to understand and recognize these social determinants, and we need to continue pushing to avoid preventable deaths. In many places within countries and across countries, there are still avoidable, preventable deaths. We wanted to continue, that is unacceptable, and we need to push, for equity in everyone achieving a kind of, a healthy lifespan. But we also wanted to say, well, actually, there are then significant challenges and inequities in how people are dying, and we need to understand these social and structural reasons, rather than just trying to fix it with a service response. So, and that we put that first because we really wanted that inequity to be absolutely front and center.
Yes, that makes so much sense, that we need to begin to look at that in our own communities, wherever we are. What are the gaps, and what is not being done for various groups of people in our society. And then the second one, this is dear to my heart. Dying is a relational and spiritual process rather than simply physiologic. We talked about that as well, but it's key. It's key to this entire conversation, and key to the changes that we want to make.
Exactly. And we were really mindful when we were writing this, that we were writing for a broad audience beyond palliative care, and for people within palliative care, this is a fundamental tenet and something that people hold dear. But actually, anyone who spent any time on hospital wards or out will see that often dying is reduced to a series of biomarkers or a physiological kind of failure in tests. And so there's such a huge literature on the role of relationships and the importance of connection and relational, the kind of, rather than the transactional, which again we come on to. So transactional being, you go and see someone tick, they've got a hospital bed being delivered, they've got the right dose of morphine written up, but actually you're not connecting with someone as a human being, you're not recognizing their own human being. It's that difference between being a patient and a person. And we wanted that to be really clear, that actually you cannot improve care or change experiences for people who are dying, people who are caring and grieving, without acknowledging the relational part of that, both with you, whoever you are in that role, interacting with that person, bringing that human element in, but also understanding within their kind of support network, the people, how it will be affecting them. The relationships are so crucial. And I think in medicine, particularly, we're very bad at doing that. I think some of the other disciplines coming into palliative care and social work and nursing are much better at understanding that role. But the relational, I see, is often entirely absent. And we need to bring that back in. And we put spiritual there as well, because not just the kind of, ticking the box of you asked a question about someone's, religious beliefs or their care, actually understanding this kind of existential event and bringing that spiritual dimension is essential for dying well, and you cannot do it without that. So no matter how much morphine availability and 24-hour access to phone lines, etc., those are really crucial parts of dying well, but only in that they support and allow the relational and the spiritual to become central. And I think that's such a great discomfort with a lot of healthcare professionals in letting that really be realized and understanding what that means. So I think there's a lot of work that we need to do to realize that principle.
It's so true. And I think one thing that struck me when I first started working in hospice is that the physiologic aspect of death and dying was the least interesting part of what was happening. I mean,
Yeah.
we had plenty of protocols and algorithms for pain management and managing symptoms, but it were the relational and the spiritual aspects of what was happening is what was fascinating and so unique and so different for every person.
Yeah.
And so much room for creativity and for offering just the right kind of support that could really change this process and how it was experienced by the patient and their loved ones.
Yeah, absolutely. It's just harder to make a protocol for it. It's harder to measure a metric. It's harder to look at outcomes. It's harder to train people. So, it's kind of slippery. You kind of feel you grasp it and then it falls between your fingers. So it's so important. Yeah, I think there's many reasons as to why it goes down. And it's a problem for more broadly in healthcare and outside of healthcare. Relationships, it leads a bit onto the next principle, but when you start looking at some big studies that have looked at the quality and nature of people's relationships around them, and then their health outcomes or outcomes around happiness or well-being, they're correlated entirely. Relationships, we are relational beings, and somehow the kind of the central part of that has been lost as we've been kind of cast as physiological beings and the relational is gone. But if we neglect that, it's at our peril, really, because there's very significant studies demonstrating that, even if we don't understand that intuitively as people.
Yeah. And I think one of the secrets I felt that became apparent to me in working with dying is that the dying process itself is actually an opportunity to heal and sometimes shore up relationships that have maybe been damaged in the past when it's approached from that respect. Like, these relationships are very important and we want to spend time talking and working on what needs to be healed in the relationship, because it can be transformative for everyone involved. And the dying process itself, it is like a vehicle to allow that to happen in people's lives. And as you said, it makes a huge difference.
And they're just often not prioritized, are they? That opportunity is so significant, but often they're just not seen as part of the work of dying or caring at that time. They're kind of seen as kind of enablers to, or just not focused on. And so that's why we wanted to put that really front and center, to say, actually, in different ways, and it'll be different for different people, community settings, but these are central, and we've got to find a way of really recognizing the role of relationships and relational care at this time.
Yeah, I do. I remember one of the hospices that I worked for, because I was very interested in the relational and spiritual aspects of death and dying. And I remember we had a new CEO who came in and called me in and said, "It seems like from your notes that you spend time talking to the patients about spirituality, about and these other aspects of their lives. I've never seen a doctor do that before. And isn't that outside your scope?" Shouldn't someone else be talking about that? Why are you, as the doctor, talking about it? And I had to explain, because we're treating the whole person, and I cannot, to give the best care I can to the patient physiologically, I need to be able to understand who they are as a complete person. And it amazed me that for the CEO, that was a new concept for a doctor to bring up. And then I realized, oh no, even in hospice, are doctors not embracing this? Are they just relegating that care goes to the chaplain and the social worker? I'm not interested in it.
And it's such a danger, and it goes way beyond kind of our care at the end of life and in hospices and palliative care, where I think there's at least a recognition of the importance of this, whether it might be given to different, you know, disciplines within it, but there is a recognition. Whereas in healthcare and social care, I think more broadly, there may be a recognition, but there's no space given to that importance. And I think there are so many examples of people trying to bring this back in and understanding this kind of transactional versus relational, and the role of compassion and of bringing yourself in. So I think this is being realized through many different domains and from many different angles. But I think it's really fundamental to something, to all of death and dying, and certainly to beyond kind of palliative care. You know, healthcare could learn a huge, and social care learn a huge amount from that.
Yeah, that it's so true. And that does lead into the third principle, which is that networks of care lead support for people dying, caring, and grieving. And this idea of networks, and really, I think the palliative care team or hospice team, that's like a microcosm of a tiny network of people working together to provide care. And you're talking about community-wide. There's a much bigger, and maybe bigger than just a community networks. And I love that idea.
Exactly. And so kind of building on, well, if we say the relational is so fundamental to experiences at these times, then kind of the next thing is, well, how do we capture that? How do we kind of really build on that? And so that principle was saying we had this vision that for everyone who's caring, everyone who's dying, everyone's grieving, have a network around them. Now, to some extent, for many people, that does happen already, but for many people, it doesn't. So we were saying, actually, this is a way of making a kind of a real statement, a real recommendation that everyone needs to have that. And we were building a bit on that old saying that it takes a village to raise a child. And, you know, many people have moved that to death and dying, and saying it takes a village to support someone to die, to care, or to grieve well. And it's really the basis of what compassionate communities movement is based on. And it's saying we need multiple people around us. We need relationships, resources, things we can draw on to allow these times to go well. And certainly in my clinical care, when I'm a community doctor, so I spend a lot of time looking after people at home. And when I see people dying well, in terms of how they would rate that, or caring or grieving well, it's not because they've got one great carer or one great doctor or a great set of medication or a really brilliant hospital bed or a really important chaplain who's giving them space to talk. It's the multitude. It's all of those different influences which are different for different people. And so what we wanted to say here is, often there's a really good, say, palliative care team or a primary care physician or someone who's involved. And that often is the way, that's what the network is conceived of. You know, you might be trying to talk with the oncology team in the hospital or the primary care or the palliative care physician. And that's often, and that, you know, an entire podcast could be on the challenges of integrated care and the kind of issues with talking and sharing, you know, care across healthcare professionals. But what we wanted to say in this is that is absolutely important, but that's not enough. And some great research from the University of Western Sydney with Kerry Noonan and Debbie Horsfeld and Rosemary Leonard, who have mapped the networks of carers who are caring for people at the end of life. And they have said, look, who's important, where would you put them, and what are your ties to them? And there are these amazing images that they've shown of these networks, and the family, the carers, the people who are living nearby, community members are kind of clustered around the carer, and right out on a limb are often the community nurses, the hospital doctor, the palliative care doctor. And what we're saying is we need to bring these networks in, because both are working really without any ways of communicating between. And we can only do it if we understand that the network is more than the professional. It's more than the health and clinical care. It's more than just a single carer, the key carer or the next of kin. It's everything. And to really have those conversations, then that's going to be looking at different things like kind of risk, power, responsibility, language, you know, how you really start having conversations about that. But again, it's an absolute essential next step if we are to really shift experiences and rebalance death and dying. And so we urge people to kind of think who they're caring for, or in whatever role they're in, to think, okay, who else is in this network? Who do I need to reach out? Who do I need to have conversations with? Who else is in this area? And there's lots of good techniques actually from social work doing echo mapping, where you draw, the person in the center, or either the carer or the person who's dying. They say who's important to them. How can we begin using some of these tools to say, okay, tell us who is in your network, so we can work out, rather than disempowering and coming in, taking over as healthcare professionals, how can we fill the gaps? Who's important for us to talk with? And it's those kind of different approaches that will really shift experiences, rather than our kind of really siloed, it's an overused word, but it is true as to how kind of healthcare is being managed, social care or community support.
I love that idea for caregivers as well, to make the diagram, as you were describing, of themselves in the center and who's there for them. Because I think sometimes caregivers get so overwhelmed by the tasks they're doing, they forget that they actually may have a better network of support than they realize. And if they can put it down on paper and see it, that may remind them to reach out more and call upon the people who are there and the groups that are there that could be helping them. But they may get lost in just being a solo caregiver and trying to do everything themselves. So it's just such an important exercise to remember that.
Yeah, absolutely. There were some great apps as well, and different ways of kind of bringing in different roles and different networks, and giving people tasks and jobs, because it can be quite tiring kind of coordinating that as a caregiver. But there's lots of different ways of text helping, but often just a piece of paper and a pen is often as effective as doing that. And then supporting people to see what are the resources you've got, who could you draw on. And one of the key things is, particularly in compassionate communities, is saying, okay, well, grief and caring and dying are universal issues, and they affect people, for those left behind, for the rest of their lives. Alan Kelleher always says grief is a forever issue, and we need forever solutions. So the point about healthcare service is they're episodic. They come in and they leave. And so what you don't want to do is kind of go in, unwittingly take over, manage things for someone, but then when the services pull back, there's nothing to fall back on. And so one of the important things is saying, well, how have you managed this before in times of crisis? Who have you drawn on? Who's helped you? What resources have you used? And that's a question we just don't really ask in palliative care. We come in, don't worry, we've got an occupational therapist, we've got a physiotherapist, we've got chaplains. You come in because, with the best intentions, we want to improve things, but we have to be thinking about, when we step back, who will be helping and what resources will they be drawing on? So how can we ensure that we, again, a part of this kind of network, we're in there, we're filling gaps, we're supporting, but we're not kind of taking over and then withdrawing.
That's so true. That's such a good point. And when I think about networks of care, I think as well that healthcare providers need networks of support around them. And the COVID pandemic made this really clear when we saw how stressed and burned out and overwhelmed healthcare providers became, especially providers who were dealing with a lot of death and dying and had no training or experience with that before. So it's something we need to think of for our colleagues too, as we work together.
And so many of these principles have got such relevance in death and dying, but actually the principles are so important for just living our lives well and running health and social care well. So they're really relevant for all of us, but often they're forgotten in death and dying and grieving, which is why we've kind of brought them back so centered. But yeah, they're principles for how we can have a good society.
Yeah. And for the fourth principle, which I also really love, conversations about death, dying, and grief become common. And that's part of why I started doing this podcast, was so that you and I can have conversations, other people can listen in and themselves get more comfortable with that. It's not that hard to talk about death and dying, and it's actually beneficial, and it feels good in a way to talk and have these discussions and to listen in. But anyway, I really value this principle, because it seems like that's foundational in a way to the changes we want to see.
And I think we felt that, the first step in rebalancing how unbalanced systems are is by people taking control and having conversations. And there's lots of movements, and death cafes, death over dinner, death festivals, death awareness days. Is, so many countries have got these ideas. And so that, that's one way of beginning conversations. But what we saw beyond that is that a lot of policies, for example, so looking at frailty or healthy aging, COVID, when we began analysing them, like the NHS strategy in the UK, no mention of death and dying. It's as if it just doesn't happen. So, you know, with aging, frailty, or even the social determinants of health, that ends at retirement. And so we felt that there's this kind of larger silence really on death and dying. And it always surprises me because there's few things that touch everyone in a population, that cuts right across. And caring, dying, loss, that is something that will affect everyone, a bit like the air we breathe or other things that affect everyone within a community. And so it always surprises me that somehow death and dying is just relegated to a subsection under palliative care. You know, these should be, all healthcare policies should be death literate. They should acknowledge that people will die, how all healthcare professionals shouldn't be just learning palliative care training or generalist palliative care. They should be learning about death and dying and how it affects everyone within that field, and they should have the skills to care for people, support people, not the specialist level of complex symptom control, but understanding death, dying as universal issues that have significant impacts if managed poorly. And so we kind of pushed for, you know, conversations, recognition, ending this silence really is on that. So policies need to respect it. They need to be narratives. Catherine Mannix from the UK talks a lot about ordinary dying or everyday dying, and it's not present. Whilst kind of death in some ways, sensationalized death is in movies, it's on the front page of newspapers, it's somehow everywhere, but what isn't seen and what is hidden is the kind of dying that most of us will have from dementia or from another non-communicable disease or frailty, often in later life. And there we find people have no script or narrative when that happens because it's kind of hidden. They've not seen it. It's often taking place within institutions or within homes. And so, you know, these should be stories on soap operas. They should be discussed in the media, these kind of stories, so that people can understand, okay, this is a part of life. This is likely to happen to me or some of my family members, and not in a kind of morbid way, but in a way to say, let's give it space so that when these times do happen, they do not kind of blindside people from left field, that they've not thought about it. They can say, actually, I read an article about that. Yeah, I saw that was a storyline in the soap opera. Yeah, okay, I kind of have a sense of that. And all of these things, along with shifting policies and having more open conversations, will begin to rebalance systems so that people are more aware of these times. And then that allows us to be more prepared for when they come, and that then improves experiences when we're not kind of trying to start and think about what we think when we're in the kind of acute crisis of something.
Mm. So true. I was thinking of like the popularity, at least here in the US, of they call it reality TV, except it very rarely includes death, dying, or grief. And so how real is that? You know, that we call it reality TV, but we're leaving out one of the most ubiquitous and very real aspects of life.
Absolutely. Well, maybe that's something, maybe that's an idea you can put to a TV producer.
Yeah, definitely. I think it can make a difference. We are seeing more and more series and programs that are bringing death in, and the death
I
of
would totally agree.
a major character. So it's really good to see that in the media, because that will help things shift.
And I find whenever I talk about this with people will always bring the personal. They'll say, yeah, well, you know, they'll talk about a family member or someone who died or an illness themselves. And people say these are important issues. So when you talk to people individually, they often are not trying to shy from it. They're saying, absolutely, this stuff's important. It's hard, it's upsetting, and it can be really difficult. But it also can be really uplifting and provide opportunities to connect, as you mentioned. You know, it's not necessarily all pain and sadness that is there. And so there's something about when we then move to a kind of societal approach, people aren't wanting to kind of have these discussions out there, but individually people will almost always say, absolutely, this is hard, and it was made harder by the fact that I didn't know who to talk to, I didn't know what to do, and I didn't have the skills to understand how to manage this. And that's what people who I meet want more of, and this idea of kind of death literacy. You know, people want to be empowered to know how to manage these times.
Yeah, so true. And that's something I observed in being involved in some death cafes as they were beginning, is that it seemed like there was this pent up need for people to come and talk about death. And always in every death cafe, there was a surprising number of people who showed up, who just saw a poster somewhere and came. But it told me that people have a need, and they just need spaces, and they need permission to talk about it.
And I think all societies need a kind of way of understanding and of making sense of our own mortality, of loss, of supporting, and whether that's through rituals and traditions. I mean, most kind of art, poetry, music is often around loss and us making sense of that. And we need that. That's a really a basic human need. And I think one of the things we looked at in the commission is that a lot of the more, say, the traditional ways of coping are being eroded by shifts in how people are living, and there's nothing that's really replacing that. And I think people then feel quite adrift, both in terms of norms around caring and supporting people, what happens when someone dies, and then specifically into grieving and bereavement. And we saw that so clearly in COVID with the fact that funerals couldn't take place and people were trying to do things online, all of the kind of the coming together, the kind of communal nature that so underpins so much of kind of grief and bereavement rituals across countries couldn't happen. And we saw the kind of the difficulties that face. So, COVID again exemplified many things, but this is something of a broader challenge, and people feel really untethered with that. And so one of the really urgent questions I think we have across different societies is to think, what place does death and dying have? And then what rituals and support do we create in the 21st century that support people to deal with loss? Because as we said, you don't get over loss. It's something you kind of incorporate and integrate into your life going forward, but that's not always that straightforward to do just by yourself.
Yeah, so very true. And that brings up the fifth and final principle of the realistic utopia is that death is recognized as having value, which is kind of the purpose of the entire report. So it kind of sums up all of that. But how can we help? How can we help make sure that people recognize the value of death? And I know you talked to me before about wanting to kind of focus in a few areas that could have the greatest impact. And so maybe we could talk about that a little bit.
So I think this was definitely the most kind of abstract principle, the hardest one, the fifth one, to kind of to explain and to kind of think what this would mean for action. And this is where the philosopher on our commission was really key in kind of understanding what value means. And it's not just kind of, ascribing like a monetary value or prioritizing it, but it's saying it is an integral part of our lives. And caring for the dying, us understanding our shared mortality is difficult, but it can bring a kind of understanding of our commonality, our fragility, our kind of connectedness. And so we had one of the boxes, one of the panels in the report is around the gift of death, and understanding what it can bring, and again acknowledging the pain that comes with that, but the kind of the part that's part of life actually, and that the kind of the light and dark and shadow and light is part of our human existence, and it's often it's painful, so we try to hide it away, but actually I've spoken about the kind of the damage that can do. So yeah, this idea of value is kind of philosophical and reflective, and really underpins everything, all of the recommendations and the earlier principles. If we began to try and realize those, then we would be revaluing death, and we would be allowing it a place in our lives, in our society, in our healthcare institutions, in our world. And that's really what the aim is, to understand that death is a part of our lives, and that we need to recognize.
That's beautiful. I know when you and I spoke before, you were saying that death literacy is really one of the an overall focus that you feel is most important for all of us, maybe all of us, to put our energy toward. And it's interesting because like over the last month or so, I've been having these conversations with ChatGPT around death and dying. And I asked, what are the most important things we need to do to improve end of life care? And ChatGPT said the number one thing is death education. And I thought, wow, even an artificial intelligence recognizes that we need death literacy. So yeah, I thought that was interesting.
That's interesting. That's not something I've asked. I've not engaged as much as I should do with ChatGPT. So that's great to know that. And that, the commission was really big, and we wanted it to be really kind of broad, wide ranging, going into lots of different ideas, because that's what death, dying and grieving are. They're broad, they affect so many different areas, but we understand that the recommendations are huge, and where do we start? So one of the key ones, we put some recommendations for all, and one of the really fundamental things, and in my reflection, it's now a year and a bit since we published the Commission report, one of my absolute key reflections is where we need to start is death literacy. And death literacy, often we talk, well, health literacy is a concept that people understand. It's, having the knowledge, the skills, the confidence to make decisions about your own healthcare, other people, and make decisions that improve and are in line with your wishes. And so again, the same idea of death literacy, it's around skills, confidence, knowledge, experience that allows you to make decisions for yourself or for others, and create a network around you, begin having conversations, those kind of skills. And so we often look, when we talk about kind of death education, often you think, well, is it, often the kind of professionals need some education, and we need specialist teaching sessions for primary care physicians, and we need kind of often kind of community education is thought of as separately. But what we're saying is everyone needs to be death literate, actually, and it depends on where you are. If you're going to be a palliative care professional, that's a very different level of death literacy to if you're working in a funeral home, and that'll be a very different type of death literacy that you need to support people. Or if you're in caring and you're, say, being a volunteer or supporting people at home, that's a different level to if you're a primary school teacher or an early school kindergarten teacher. What are you needing to teach then? But actually all of us need to have an understanding of the role of death and dying and how to support people who are facing it. So death literacy is a kind of essential for everyone, but the level of that and what that means to you will be different. But we wanted that to be for professionals across society, for policies to be death literate, schools to be death literate, hospitals crucially to be death literate. So, and that's I think the really key thing that will underpin much of the subsequent change, or create a space where that subsequent change can then take place. So it's really the first step.
I think that's so true. And from the high level, it almost seems overwhelming, like, oh my gosh, how are any of us going to help improve death literacy? But it's really a matter of, when you're sitting with a couple of friends over coffee, being comfortable to say, I know your mother died recently. How's that been for you? And how, what might you need, to just be able to bring it up and just have these conversations one-on-one with people, and to get comfortable doing that. That's how simple it could be for us, each of us individually, to get started.
Absolutely. And knowing, where people, you can get support, how did someone else, there's so much intrinsic knowledge within communities about, and that's why often connecting someone who's cared for someone at the end of life with someone who's doing that now, there's so much knowledge in that. How can we kind of transfer or share some of that that death literacy, that knowledge about how you care, how you die well in this particular community, in this setting? That knowledge is often there. And there's some bigger projects then that look at first aid, is something that we often teach, kind of essential first aid. If someone falls over, collapses in the street, we all know what we should be doing, and that's taught in schools and universities and etc. And so some teams in Europe have switched that over to last aid, saying, well, actually, all of us should know how to respond if someone is bereaved at work or distressed. Everyone should know what, at least something to say, or how to help them. Or if someone is caring or someone is dying, how can we support them? And that these are core skills that all of us in society should have. And I like that idea of, actually, this is something that it's a core skill for being human, and we can do that in a small way with our friends, or we can do it in a larger way, say through work. But that's the key thing, that it's all our responsibility to think about, how have I got the knowledge and skills to support people and respond to those in need.
And I would like to suggest that reading this report from the Lancet Commission is one way for people listening to improve your own death literacy. It's a fantastic report. And even if it feels like it's too much or too long, there are really wonderful inset panels that kind of summarize the really important points. And you can just read those and you come away with a much bigger understanding. And I will link to the report in the show notes, and it's beautifully written. I will say, like, I just felt touched so many times in reading it. And I resonated so much with the approach of this report. Unlike a lot of other academic pieces that write about death and dying, there's a lot of heart and soul in this report.
Oh, well, it really, there was so much in the meetings, the discussion, the thought, and people's contributions that we really wanted to bring that through, and we wanted it to really speak to people, because this is an experience. These are experiences that people will bring their own experience, their past, their own bereavements, and their own wishes and hopes too. And we really realized that. So we were wanting to bring kind of the academic, but also the heart and the meaning, because these are events that they're social, collective, communal events, really. So acknowledging the person and the reader we knew people would be going on their own journey as reading it in a different way, to see if you're reading something on hypertension or something maybe.
Yes, exactly. Well, I had hoped today that we'd have time to talk about compassionate communities, but that's really such a big subject. It needs its own separate interview. So we will do that. We'll come back together again to talk about it, because I feel like we can't do it justice, and we're running out of time now. So as much as I hate to ever leave anything, any topic untouched, but we will return to it another time.
And do it justice.
Yes, for sure, because I wouldn't want to short that, but that's something for listeners to look forward to. We will come back and really dive into compassionate communities. Well, Libby, thank you so much just for sharing all of this wisdom. And I just want to thank you for your role in writing this report, which is phenomenal because of your involvement. I believe I believe that your contribution has been beautiful, and this report is essential. I think it's going to guide us for a long time in where we need to start and what kinds of changes we need to be making.
Exactly. And that was our goal, to kind of capture so much thinking and discussion, distill it down, but then put it into a form that people can act on, because that's the key thing: to read it, distill it, reflect on it, and then act on it in a small way or a large way. But that's what we ask of people.
Exactly. Ah, that's so true. And so for everyone listening, remember that everyone can do something. It may seem like, oh, these problems are huge, there's nothing I could ever do to fix it, but it's going to come from the grassroots in a way. It's going to come from individuals deciding, I want to make things better, and I'm going to pay attention in my neighborhood and watch out for someone who might need more support, and figure out how to improve our networking and taking care of one another in the community.
Exactly. Yeah, absolutely.
Yeah, so very true. Well, thank you. I'll remind listeners, I've been talking with Dr. Libby Sallnow from London, and it's been just wonderful to have this discussion with you again. So thank you so much for giving me your time.
Thanks so much for inviting me, and I look forward to part 2 on compassionate communities.
Oh, yes, me too. Take care. I hope you enjoyed my conversation with Dr. Libby Sallnow. And remember our takeaway message that death literacy is one of the most important goals we can have right now for changing end of life care. So learn what you need to learn about death and dying from this channel, read books, listen to podcasts, get the information you need, and then be sure and talk to other people. Tell people what you're learning and how it's making a difference in your life. And share this YouTube channel or the podcast with them. And until next week, remember, we're here for love. So face your fear, be ready for whatever life brings you next, and love each and every moment of your very fleeting life. Bye-bye.